Are you ready to learn with fun? Brace yourselves for the ultimate test of knowledge in the Cardiac Super League. Witness the clash of giants as 12 formidable teams step into the arena, battling it out for cardiology supremacy. In this exciting collaboration between Wilson's Pharmaceuticals and the Pakistan Cardiac Society, the Cardiac Super League promises intense competition and groundbreaking learning experiences. Stay tuned as the teams showcase their expertise, strategic brilliance, and unwavering determination. Who will emerge as the true champions in cardiology? The main goal of the case-based learning approach is to equip students and healthcare professionals to refine their clinical practice by learning the latest advancements. The Cardiac Super League awaits you, guaranteeing to advance your education. Join us and become part of an incredible journey. Visit our Facebook page or contact us for more information.
Bismillahirrahmanirrahim. Assalamu alaikum everyone. This is 𝐂𝐚𝐜 𝐒𝐿 and welcome to Pakistan Cardiac Society's Cardiac Super League powered by Wilson's Pharmaceuticals. Today we are live for the 10th match of Cardiac Super League, which is between 𝐂𝐚𝐜 Stars and P.I.C Peshawar Warriors. It is an important match because this match will decide the fate of the Group B, and two teams will qualify from the Group B, and the result of this match will decide the fate of these two teams. And one team will obviously be knocked out of the competition, and both two teams will qualify for the quarterfinals. Allow me to introduce the expert panel with us. Today we have with us Dr. 𝐂𝐚𝐜 𝐒𝐚. He is consultant intervention cardiologist at Queen's Hospital, Birmingham. He is the umpire of this match. And very soon, another guest panelist, Dr. Hamid Sharif, will also join us today from his assistant professor of cardiology at Rawalpindi Institute of Cardiology. And second guest panelist is Dr. Imran Hamid. He is Vice President of Pakistan Society of Echocardiography, and he's also concerned cardiologist. And last but not the least, moderator of today's program is Dr. Hamza Ghori. And I will request Dr. Hamza Ghori to please start the formal proceeding of this match. Over to Hamza Ghori.
Thank you very much, Hamza. It's great to be back after a while, and I think it's a crucial game today, 10th match of the league between Aga Khan University Hospital Stars and Peshawar Institute of Cardiology Warriors. Now, obviously, we all know that this Cardiac Super League is powered by Pakistan Cardiac Society along with Wilson's Pharmaceutical. So I think they deserve a big round of applause, no doubt. Now, with this, I think I would like to welcome our council members, worthy council members, along with the umpire. And we are lucky to have Dr. 𝐂𝐚𝐜 𝐒𝐚, interventional cardiologist from UK. And I think as we have more panelists and our rest of the council members, and we'll have their words and their expert opinions in. So with this, I move towards our two teams. I would like the two teams to give their introductions. So the captains, please. First, I would like Peshawar Institute of Cardiology Warriors to give the introductions.
Assalamu alaikum, sir. My name is Dr. Noman Munir Khan. I am captain of team Peshawar Institute of Cardiology. On my right side is Dr. Haider. On my left side, Dr. Hassan. And on the left of Hassan is Dr. Wali. And inshallah, we are hopeful, and inshallah, we will win to one match.
Great. Best of luck. So, Aga Khan Stars, can we have the introductions?
Yes, good afternoon, everyone. My name is Dr. Mohammad Ahmed Tamiz, and I'm the captain of Aga Khan Stars. On my right is Dr. Asfandiar, and then Dr. Umair, and Dr. Rizwan is on my left. So all the best to the other team.
Yeah.
Right. So with this, we now move on to the coin toss. It's going to be an electronic coin toss. So I will randomly select one of the teams. So P.I.C, Warriors. Heads or tails?
Heads, sir.
Okay, so they've called heads. Roll, please. So I guess tails it is, right? So we have Aga Khan, who has actually won the toss. So Stars, are you going to take the questions first, or you want to throw the questions?
So we are going to take the questions first.
Okay, so they're going to take the questions, and that's the news from the center. So P.I.C will start the questions, and can we have the vignettes on the screen?
Okay. Yes. Thanks.
Please read the question. So each team is going to get 90 seconds. I think we are all aware of the format. And once you're done with reading the question and along with that, going through all the list of options, we'll start the timer. So please start and read the question.
Okay, sir. So the question is, 86-year-old female with the history of severe aortic stenosis, mean gradient 40 mmHg, peak velocity 3.1 millimeter per second, and AVA continuity equation around 0.9, had a fall and broken her neck of femur. Before this event, she was asymptomatic and could easily walk 20 city blocks at her own pace. She is quite incapacitated because of her injury and insists orthopedic surgeon for early fixing. The anesthetist is quite concerned about her aortic valve disease and wants cardiac clearance. Pulse is 76 with no radio delay and significant radiofemoral delay. There is no cyanosis or clubbing and maintains saturation at room air.
Okay, so move to question number 1, please. And with that, I would also like to welcome our guest panelist here. We have Brigadier Abdul-Hamid Siddiqui. So welcome, sir. It's great to have you. Question 1, please.
So question number 1. Which of the following is the most appropriate line of action according to the guidelines in her case? Option A, she should undergo aortic valve intervention before hip surgery. Option B, she can undergo hip surgery before aortic valve intervention. Option C, she should undergo aortic valve intervention and hip surgery simultaneously. Option D, she should wait for 3 months before any intervention. Option E, she should not undergo any kind of intervention.
So timer starts now, 90 seconds.
Can we look at the scenario also?
Yes. So can we have the vignette on the screen as well, the scenario?
Can we have a look at options again?
Options, please.
So I have the answer.
30 seconds almost. So you have the answer?
So it's option B. She can undergo surgery before aortic valve intervention.
So it's option B. B for bat, right?
Yes, B for that. B.
Okay. So lock it now. Can we have the answer? Oh, great. Well done. So you start off by hitting a 6. Well done. Great. So next question, please. Question number 2. Can we have question number 2?
So question number 2, according to revised cardiac risk index, hip replacement surgery is option A, extremely low risk surgery as far as preoperative cardiac events are concerned. Option B, low risk surgery as far as preoperative cardiac events are concerned. Option C, intermediate risk surgery as far as preoperative cardiac events are concerned. Option D, high-risk surgery as far as preoperative cardiac events are concerned. Option E, extremely high-risk surgery as far as preoperative cardiac events are concerned.
And timer starts now.
It's not.
It's not B. According to our especially
So all the so we have the answer.
So you have the answer. That's quick. Are you sure?
Yes.
Should we lock it?
Yes, it's option C, intermediate risk surgery as far as perioperative cardiac event is concerned.
Okay, lock the answer. And is it true? Yes. Well done. That's great going. Another 6. Wonderful. Moving on to question number 3.
So question 3. Which of the following statements is correct? Is incorrect, sorry. Renal transplant is a high-risk surgery for preoperative cardiac events. Option B, breast surgery, lympectomy, simple mastectomy is a low-risk surgery for preoperative cardiac events. Option C, cardiac endarterectomy is intermediate risk surgery for preoperative cardiac event. Option D, laparoscopic appendectomy, cholecystectomy is a low-risk surgery for preoperative cardiac events. Option E, pulmonary or liver transplant is a high-risk surgery for preoperative cardiac events.
Okay, timer starts now.
Yeah, ये सही आंसर और ये ठीक है
not a high risk.
So I will also request both the teams to be on unmute while they are discussing. Yeah.
Yes, but
Why do we do for each time?
30 seconds to go. Closing in on 10 seconds. Hurry up.
All right, so we have the answer.
Yes.
A, renal transplant is high surgery for perioperative cardiac events.
A. Okay. Lock it. Is it true?
Let's see. Yes.
Oh, yes. Well done. Well played. So it's 3 in a row. Wonderful. So question number 4 on your screen.
So question number 4, as regards preoperative cardiac evaluation for non-cardiac surgery, which of the following statement is correct? Option A, there is no association between left ventricular ejection fraction in preoperative events, particularly if EF is less than 30. Option B, echocardiography is rarely indicated if there is a suspicion of cardiomyopathy or valvular heart disease. Option C, routine preoperative evaluation of LV function is indicated in all patients. Option D, routine preoperative beta blockade started within 24 hours of surgery is associated with death, stroke, hypotension, and bradycardia. Option E, beta blockers should be started on the day of surgery.
Timer starts now.
All right. Option there is no solution. This is C. There is a solution. Then option B, echo is really indicated. It is indicated when we are suspecting cardiomyopathy.
हर एक मरीज में नहीं करते हैं
आप पैकेजिंग करते हैं
जो जाने देते हैं
ऑप्शन डी जो है देयर इज उसमें it is mentioned that it is
मुझे कंफर्म कर रहा है क्योंकि ये penicillin agent में indicated जिसमें LV dysfunction indicated.
And so I have
और ये भी सही.
this article it was mentioned it is related. So sir, we have the answer.
नहीं critical 24 hours ताकि हर problem.
So the answer is option D.
Option D. Okay. Should we lock it?
No, just a minute.
Okay, take your time. 30 seconds to go.
Same D.
Option D. Option D.
Sure?
Option D for delta.
Okay. Can we have the correct answer? It's option D. Oh, yes. Wow. I think they are making it difficult for P.I.C. They must be under pressure. Well done. Yet again. 4 6s in a row. Great job. So, question 4. Now we have question number 5 on your screen.
So question number 5, as regard dual antiplatelet therapy after stent implantation in non-cardiac surgery, which of the following statements is incorrect? Elective surgery should be delayed at least for 4 to 6 weeks and preferably for 6 months, irrespective of type of stent. Introduction of dual antiplatelet can be done 14 days after balloon angioplasty. Introduction of dual antiplatelet can be done 60 days after drug elastic stent angioplasty. Introduction of dual antiplatelets can be done 30 days after bare metal stent implantation. Option E, interruption of dual antiplatelets can be done 3 to 6 months after DS angioplasty.
Timer starts now.
नहीं B. Correct switch. Correct मालूम.
Incorrect. So elective surgery should be delayed at 4 to 6 weeks. This is the correct option. Interruption of dual antiplatelets can be done 14 days after. Guidelines is 2 to 4 weeks. So yes, I get. So
C 3 months.
Interruption of dual antiplatelets can be done 60 days after the death. Stent angioplasty is 90 days. Then option D is interruption of dual antiplatelets done 30 days after bare stent.
40.
This is 2 to 4 weeks. And then option E is interruption of dual antiplatelets can be done 3 to 6 months.
ये भी सही बात है.
So the option is C. So agree. So we have the answer. It's option C. Interruption of dual antiplatelets can be done 60 days after coagulating stent angioplasty.
Are you sure?
Yes.
Okay, lock the answer. And wow, I just wanted to see whether you guys get it right or not, but well done. That's 5 in a row now. 5th 6. That's great. I think you're absolutely spot on, and I think the way you are getting the answers, the camaraderie is wonderful. So, next question, please. Question number 6.
So question number 6, as regards discontinuation and reinstitution of dual antiplatelets therapy after stent implantation before non-cardiac surgery, which of the following statements is correct? Option A, continue aspirin and discontinue clopidogrel 5 days before surgery. Option B, continue aspirin and discontinue prasugrel 5 days before surgery. Option C, discontinue aspirin and ticagrelor 7 days before surgery. Option D, discontinue aspirin and clopidogrel 7 days before surgery. Option E, resume P2Y12 inhibitor after 96 hours without loading dose.
Okay, timer starts now.
Correct. As regards discontinuation, reinstitution of the therapy, stent implantation before the non-cardiac surgery. Which one is correct?
Correct is A.
Continue aspirin. So we'll continue aspirin.
We'll discontinue clopidogrel 5 days before, and then we'll start the clopidogrel on the day post procedure.
Regarding option one, we'll continue aspirin and discontinue prasugrel 7 days.
7 days के prasugrel.
Continue aspirin
4 to 5 days. 4 to 5 days.
And option D, discontinue aspirin clock 5 days, 4 to 5 days after. So
that's A.
So, sir, we have the.
You have the answer?
It's option A, continue aspirin and discontinue clopidogrel 5 days before surgery.
Should I lock it?
Yes, sir.
Okay. Option A. Show us the correct answer. Oh, yes. So I thought, yeah, I knew you would make it. Well done. So I think we have 6 on 6. Very well done, Aga Khan. Stars. Stars are going high. P.I.C, you need to bowl faster. Come on. And question number 7 on your screen.
So question number 7, as regard discontinuation of anticoagulant therapy, generally before non-cardiac surgery, which of the following statement is correct? Withhold warfarin typically for 5 days, withhold dabigatran typically for 4 days, withhold rivaroxaban for 3 days, withhold apixaban for 2 days, withhold eroxaban typically for 1 day.
Timer starts now.
So it's between 7 दिन बेस करते हैं, but नहीं इसके लिए usually करते हैं एक हफ्ता पहले करते हैं. So अभी right now 5 days के करीब ही है. So option है. I'm not sure. 4 days नहीं 4 days नहीं है. नहीं because after 2 days ये सारे दोनों 1 day so we are from typically 1 so
30 seconds left.
So we need to answer.
Okay, go ahead.
It's option A, withhold warfarin typically for 5 days.
So you're saying option A for apple.
Yes, A for apple.
Okay, lock it and show us the correct answer.
Yes.
Oh, it's a big yes. I can see that. And now P.I.C must be under a lot of pressure. 7 on 7. Wonderful. 7 sixes in a row. Very well done. And with this, before moving on to question number 8, I would like to welcome our worthy council members, Professor Javed Syal and Professor Ambar Ashraf. Welcome, sir. Welcome, ma'am. And can we have question number 8 on the screen?
So question number 8, as regards anticoagulant management for mechanical prosthetic valve before non-cardiac surgery, which of the following statement is correct? Option A, for mechanical aortic valve, risk of valve thrombosis is higher than mechanical mitral valve. For mechanical aortic valve, if no additional risk factors like atrial fibrillation, history of stroke, or congestive heart failure are present, no bridge is necessary. For mechanical mitral valve, bridge therapy with phytominidazole is preferred over unflexion or low molecular heparin. Option D, for mechanical mitral valve, bridge therapy with dabigatran is preferred over unflexion or low molecular heparin. Option E, for mechanical mitral valve, bridge therapy with apixaban is preferred over unflexion or low molecular heparin.
Timer starts now.
This is correct
Sawal as regard government for mechanical valve or a non-cardiac correct.
ये इसमें INR अपने 2.5 रखना है. That's 2.
अच्छा रुक जाओ ठीक है for mechanical valve for mechanical aortic valve no additional factors like a stroke ये होते तो तब ठीक है ये हमारे लिए for mechanical valves bridge therapy
bridge therapy
अच्छा for mechanical valve आप नहीं आप
30 seconds.
Option is B. Okay, so we have the answer. Option B for mechanical valve, if no additional risk factors, AFib or history of stroke or congestive heart failure are present, no break is required or necessary.
So
Option
it's option B, B for bat.
B for bat.
Okay, so lock option B. Is it true?
B for ball.
B for
B for
beta.
ball, yes. B for ball. Lock it. Oh, wow. That's really great going. Wonderful. 8 in a row now. Well, PIC, it's going to be tough, but I'm sure you'll put up a fight. So can we have the next question? Question number 9.
So question number 9. As regards risk stratification before non-cardiac surgery, which of the following statements is incorrect? Option A. Low-risk patients can proceed to surgery without further testing. Option B. Moderate risk patient with reasonable functional capacity, 4 to 10 minutes, can climb two flights of stairs or walk 4 blocks on level ground, can proceed to surgery without further testing. Option C. Moderate risk patients with low or unknown functional capacity, that is less than 4 minutes, can pharmacological stress testing with dobutamine or myocardial perfusion imaging study are reasonable options. Option D. High-risk patient, those with recent MI, decompensated heart failure, significant arrhythmias, and hemodynamically significant valvular heart disease, do not need stabilization and can proceed to surgery without delay. Option E. ECG can be useful as a baseline in patients with non-cardiovascular disease, arrhythmias, or structural heart disease.
Timer starts now.
So
D, correct now.
So that's incorrect. So doctors can proceed with to moderate risk with reasonable function. Actually, can then go without maybe testing. True. Moderate risk, आपको function capacity unknown या फिर low increase. Obviously, need a stress test for
Prognosis के लिए
that is true.
Then that is
And
prognosis.
option D is high risk patients
Stabilize
do
करना
not
होता है.
need stabilization. Obviously, that doesn't make any sense.
Stabilize करना. किसी को heart failure को stabilize करने की
ECG can be useful as a baseline in patients with cardiovascular disease. No, we more than that. So option D.
तो जा सकते हैं. हाँ, but arrhythmia नहीं, arrhythmia के साथ कभी भी आपने एक चीजें को stabilize करना है, उसके बाद नहीं.
For जो भी आप certification होती है वो आपकी जो है वो elective surgery elective cases के लिए होती है, not as an emergency case.
मतलब यहाँ पे हमारी सर्जरी नहीं कह रहे, हर एक पेशेंट
emergent surgery you can stratify the patient. Option D. Option D. Sir, D. My answer is option D. D for
option
doctor.
D for doctor. Okay, option D, D for doctor. Lock it. Is it true?
Obviously, yes, it should be.
Can we? Oh, yes. So, I thought you would do it in a jiffy. The way you guys were going, for me, this was a short thing, and well done. So 9 on 9. With this, I would also like to ask Hamza, have we had any match in which we've had 10 on 10 by any team?
Yes, sir. The highest score was 54.
Okay. Is this history in the making? With this, move on to the last question. Question number 10.
So question number 10, as regards cardiovascular implantable electronic device before non-cardiac surgery, which of the following statements is incorrect? Option A, electromagnetic interference from monopolar electrosurgery is the main issue. Option B, pacemaker may be the oversensing and inhibited. Option C, anti-tachycardia, pacing function of ICDs may either be inhibited or may falsely detect tachyarrhythmias. Option D, device may be reset. Option E, use monopolar electrosurgery whenever possible.
And timer starts now.
device may.
So this, they are asking for okay, regarding cardiovascular ICD, implantable electronic devices for cardiac surgery. Electromagnetic interference. Pacemaker may be over sensing side. C. Anti-tachycardia pacing function of ICDs may either be inhibited or may falsely detect tachyarrhythmias. ये भी हो सकता है. अच्छा. D. Device may be reset. Use monopolar electrosurgery when possible, more possible. तो ये तो हम फोकस ठीक है. आपका ऑप्शन ए जो है वो ये कहते हैं इलेक्ट्रोमैग्नेटिक इंटरफेरेंस मेन इशू इन दिस. So option D. The reset is
Whenever possible. Whenever possible.
option
30 seconds to go. Come on, stars. You can do it.
Device. Could you reset it?
So we have the answer.
Okay, go ahead.
Option E for eagle.
Okay, that's the last option.
Yes, last option.
Use monopolar electrosurgery whenever possible, and that is true. So very well done. That's 100% score. Wow, that's brilliant. So I think that's been a wonderful innings. No blemish anywhere, and it's a lot of pressure on PIC now. So I think with this we end the first innings, and now I would like to take, yes, it's 60 out of 60. So can we have comments from our esteemed panelists, our council members, and our umpire, Dr. Sohail Khan? Are you there?
I am, and as the umpire, I'm meant to stay neutral, of course, as you all appreciate, but I have to just give my congratulations to the Aga Khan Stars, because I've never seen a performance like this before at all. So, you know, well done, Aga Khan Stars. You've done fantastically well. The questions were not particularly easy. If you know, these were challenging questions that were being posed. So I think, you know, you've really tackled them very well. So I think, you know, we are on for a very good match. And PIC Warriors really are going to be up against it, but I'd be interested to see what their reply is going to be.
Thank you, sir.
Thank you very much, sir, for your comments. I think this will give a lot of confidence to both the teams. No doubt they've done very well, the Stars, but I think Warriors definitely going to make a match out of it. So do we have any more council members here? Hamza, I don't see anyone. Is that true?
I guess Dr. Hamid is also there, sir.
Is Dr. Hamid there?
Yes, please. Yes.
Oh, Dr. Hamid, it's great to have you.
Thank you very much, Hamza. How are you?
I'm good. So I'm extremely excited to have you today. I think they've put up a wonderful show. Your comments, please.
Yes, I think it was a very interesting kind of a battle between two very, you said, evenly matched teams. Alhamdulillah, both of the institutes are doing quite well in the field of cardiology, especially PIC, in a very short period of time, have done a lot of work. Khan, as we all know, probably is one of the world-renowned centers. So it was very nice having a close match between these two. So it was very nice having a look at them. And the important thing was the questions were very apt. They were mostly based on their scenarios. I mean, we come across these kind of scenarios on a daily basis. Acute coronary syndrome presentations and the risk stratification, that was very good scenario. Again, cardiac assessment in various surgeries is very important if you are working in a multidisciplinary setup. So evenly matched. I mean, at the end of the day, one team has to win, another has to lose. Very good exercise, this kind of, because it will inculcate the habit of reading among the upcoming students. So I'm very happy to have been involved in this matchup, and I hope such activities carry on in the future as well.
Thank you very much, Dr. Hamid, for your worthy comments and bucking both the teams up. I think they will be requiring that. And for sure, this is your everyday scenario. So with this, I think we'll move to the next innings now. And do we have the vignette ready? And are the teams ready? Okay. So Aga Khan, Stars, can we have the question? Right. So Stars, please read the question.
All right. So the scenario is an 80-year-old diabetic woman presents with 8 hours of chest heaviness. Her blood work shows elevated troponin. ECG reveals sinus rhythm with deep T-wave inversions in leads V1 to V4. Aspirin 325 mg, ticagrelor 180 mg, and 2 doses of sublingual nitroglycerin are administered. 20 minutes later, she continues to feel 3/10 chest pressure. Repeated examination shows a blood pressure of 100 by 62 millimeters mercury and a heart rate of 112 beats per minute. She appears anxious, but the rest of the examination is unremarkable. She underwent urgent coronary angiography, which reveals critical stenosis 95% of the proximal LED, with moderate angiographic stenosis in the left circumflex. However, the right coronary artery showed intermediate 60 to 70% stenosis. The decision is made to proceed with PCI to the LED with a drug-eluting stent.
All right. So can we move to the next slide, which is question number 1? So you can have this vignette whenever you want to take a look at it. PIC, Warriors.
So the question number 1 is, which of the following is a correct statement regarding this patient's management? A, bevalirudin is a safe adjunctive therapy during PCI. Heparin and tirofiban should be added during PCI. Option C, heparin and eptifibatide should be added during PCI. Option D, fondaparinux alone is safer in this patient. Option E, an ischemia-guided strategy is preferred in this older patient.
And your timer starts now, 90 seconds. So PIC, if you want to take a look at the question and the scenario, you can do that. We can bring it back.
So we want to see scenario, sir.
Okay, scenario, please, on the screen. $60 seconds.
So, sir, question.
Question, please. Question 1.
Yes.
$30 seconds. Come on, Warriors, you can do it. Okay. Approaching 10 seconds.
So, sir, option A, sir.
Are you sure? Option
Yes,
A?
sir. Yes, sir.
So lock option A. Is it true?
Come on.
Yes, well done. That's a good start. Very well done. So question number 2 on your screen now.
Question number 2, which of the following is incorrect regarding late hospital or post-hospital care of patients with non-ST elevation acute coronary syndrome? Option A, aspirin should be continued indefinitely in all NST-ACS patients at a daily dose of 325 mg. Option B, all eligible patients with non-ST elevation ACS should be referred to a cardiac rehabilitation program. Option C, a P2Y12 receptor inhibitor should be continued for at least 12 months. Option D, folic acid should not be used for secondary prevention in non-ST elevation ACS patients. And option E, an annual influenza vaccine is recommended in non-ST elevation ACS patients.
Okay, timer starts now.
Sir, we will go with option A, sir.
Are you sure? That's quick.
Yes, sir.
Okay, So lock option A. Oh, very well done. 2 sixes in a row. Well, you never know what we have in store. Good going. Great. So can we have question number 3?
Question number 3. The GRACE risk score includes all of the following except A. More than 3 cardiovascular risk factors. B. Heart rate. C. Systolic blood pressure. D. Serum creatinine levels. E. ST segment deviation.
90 seconds, start now. Come on, P.I.C, I think we are in for a hat trick. Come on.
Sir, we will go with option A, sir. Hello, sir. Option A.
Should we lock it? Okay,
Option A,
lock
sir.
option A.
Ramza, can you hear us? Connected है लेकिन कैमरा उनका ऑफ है. Let's move to question number 4.
All right. So question number 4. The TIMI risk score components for unstable angina / NSTEMI patients include all of the following except positive cardiac markers. Option B, aspirin used within the last month. Option C, known coronary artery disease of more than 50% in the major epicardial artery. Option D, age more than 65. And option E, ST changes of 0.5 or more millimeters.
Okay, timer starts now. I'm sorry, I think I got cut off. So I'm back.
Sir, we will go with option B. B for ball.
B for ball. That's your option? That's okay. So lock option B. Well done. Good job. So that's good going. So moving on to the next question, please. Question number 5.
Prior to her PCI with drug-eluting stent, she is given 300 milligrams of aspirin orally. Which is the best oral antiplatelet therapy to be added to this patient? Option A, a repeat dose of aspirin 81 mg. Option B, clopidogrel 600 mg. Option C, ticagrelor 180 mg. Option D, prasugrel 60 mg. And option E, clopidogrel 150 mg.
Timer starts now.
According to this.
Less than 30 seconds now.
Sir, we will go with option C.
Okay, C for cat.
Yes, sir.
Option C. Please lock option C. Oh, well done. Great going. So that's another one of those correct answers. We have seen all the correct answers. Well done. So moving on to question number 6.
So, of the following medications, which does not have an American College of Cardiology and American Heart Association Class 1 recommendation for use in non-ST elevation ACS patients? A. Angiotensin converting enzyme inhibitors. B. Beta adrenergic antagonist. C. Immediate release nifedipine. Option D. Non-dihydropyridine calcium channel blockers. And E. Sublingual nitroglycerin.
Okay, timer starts now. I think I would also like to take the opportunity to welcome Professor Dr. Imran Hamid. I think he's there in the panel. So welcome aboard, sir. Come on, come on. P.I.C, we've got a match on our hands. Aga Khan keeping their fingers crossed. "30 seconds to go."
Sir, we will go with option C.
Okay, so are you sure?
Yes,
Should
sir.
we lock it?
Yes, sir.
Okay, lock option C. Well done. Very, very well done. Well played. Oh, it's gonna go to the wire. And I think it's gonna make that very interesting. So with this, we move to the next question, please. On your screen. Question number 7.
Patient returns to your clinic for follow-up after you performed a PCI for single vessel coronary artery disease in the setting of an NSTEMI. She has done very well and has had no evidence of recurrent angina or congestive heart failure. She is known to have normal left ventricular systolic function following the intervention. She asks about the benefit of future stress testing and wonders if she should periodically have such a non-invasive evaluation performed. What should you tell her? Option A, stress ECG is a simple and sensitive way to predict and identify the presence of restenosis following PCI. Option B, all patients with documented coronary artery disease who undergo PCI should have yearly stress testing performed to evaluate functional capacity and to look for objective evidence of ischemia. Option C, stress testing is in asymptomatic patients is indicated only for patients with high-risk features when trying to find objective evidence of ischemia. Option D, only the presence of recurrent symptoms justifies stress testing in patients who have undergone PCI. Option E, after PCI, the only way to assess for ischemia is fractional flow reserve.
Timer starts now.
Stress testing in asymptomatic patient is indicated only for the patient with high risk features. We're trying to predict this.
Approaching 30 seconds.
Okay, sir. D. Sir, we will go with option D. D for dog.
Are you sure?
Yes, sir.
Should we lock it?
Yes, sir.
Okay, lock option D. Oh, really got close. But I think we've got the first wrong question of the day. Anyhow, I think you are still playing good, and we'll continue with the rest of the questions, right? So can we have the next question?
So the patient's grandson, who is a second-year trainee in cardiology, asks why weren't glycoprotein 2B3A inhibitors used prior to the PCI procedure? Which of the following statements is false concerning glycoprotein 2B3A inhibitors? Option A, bleeding is infrequent, although it usually occurs in hollow organs, for example, gastrointestinal, genitourinary, or vascular. Option B, TIMI major bleeding is increased by approximately 1% when using a glycoprotein 2B3A inhibitor, and this is predominantly due to an increase in intracranial hemorrhage. Option C, severe thrombocytopenia occurs in approximately 1% of the patients. And option D, thrombocytopenia is more frequent with apixaban, especially early repeat administration.
Timer starts now.
False. False. False.
One percent of the deal team is leading to a deal. 1%.
Okay, approaching 30 seconds now. Closing in on 10 seconds.
So,
Come
we
on.
will go with option D, sir.
You want to go with option D?
Yes, sir.
D for dog.
D for dog.
Option D. Lock it, please. Oh. So we got another one wrong. Never mind. I think we still have something to play for. Can we have the next question, please? Question 9, please.
So which anticoagulation regimen would minimize the risk of bleeding complications during transradial PCI? Option A, unfractionated heparin. Option B, bevaluridin. Option C, molecular. Option D, fondaparinux. Option E, none of the above.
Okay, timer starts now. I will request the teams not to speak when the other team is reading the questions. 30 seconds.
Sir, sir, we will go with option A, sir.
So you want to go with option A, unfractioned heparin, right?
Yes, sir.
Okay, lock it, please. Can we have the answer? Oh, you got that wrong. Okay. Well, never mind. I think we still have the last one to go, and we'll play for that. So, stars, read the last question, please.
So the last question. A year later, complaints of chest discomfort on exertion. Her ECG is normal while ETT performed is positive for ischemia. Her EF is now 50%. You performed an angiogram which showed patent stents in LED and intermediate looking 60 to 70% disease in RCA. How will you proceed? Option A, stent the RCA. Option B, FFR guided PCI of RCA with drug-eluting stent. Option C, medical therapy. Option D, PCI of RCA with a drug-coated balloon. Option E, defer the case and send for stress MPI.
Timer starts now.
Symptomatic there, best stick there. أخو ده ولا كتاخو treatment optimize كده دينا روستو بتوجه وتا FFR guided PCI medical therapy يعني RCA दरकार है.
Master RCA कैसे कैसे
ना स्टैंड को روستو خبر ده بيخو أغنى مكتوب FFR كه چې منغو چې دا ټریټمنټ اپټیمایز شي د چست ډسکمفورټ ته دا غنه روستو به اتفاق وکي چې مطلب هغه ده کنه دی.
was
30 seconds to go.
Was the
لا انفيسيو بول previous هغه procedure
sir, we will go with option C, sir.
So you want to go with option C.
Yes,
that is to
medical therapy, sir.
medical therapy. Oh, man, it's been a flurry of a couple of wrong answers, I guess. So we got this wrong, but I guess you've still done well. And we end with a total score of, can we have the scorecards, please? And I think it's clear to everyone that definitely Aga Khan Stars have won the game today, 60 as opposed to 36 by P.I.C Warriors. So I would like to congratulate Aga Khan University Hospital Stars for a wonderful, flawless performance, no doubt. And with this, they will definitely qualify into the next stage.
Thank you, sir. Thank you.
Very well done. And P.I.C, I think you guys did very well too. You've put up a good show. What do you think?
Sir, point scoring जो final है वो कब display होगा, sir?
Okay. So I think with this, there may be a twist in the tail, because I'm going to give you the good news, because you guys have also qualified on the basis of run rate. So well done. Well done to both the teams. Congratulations. So we've got 2 winners in 1 game. That's great. Very well done. So Aga Khan Stars, what a performance. With this, I think I would now like to take comments from our highly esteemed panel, and Dr. Suhail Khan, our umpire for the game. I'm sure he must be so proud. So can we have you?
Yes, well, thank you, Hamza, for chairing that. So this has been a superb match, and I think, you know, the P.I.C Warriors were going really well until question 7, and then sort of stumbled It was always going to be difficult because Aga Khan had put on such a fantastic performance, scoring full score, and I've certainly not seen that before. So, you know, it was always going to be an uphill struggle for the Warriors to really claw back into the match. But they, you know, they did a very good. They certainly had a good game, tried their best, and it's good to hear that they've gone through on the basis of run rate because they have been a fantastic team during the course of the proceedings. I just want to thank Saeed Hamza as well, our second Hamza. I know he puts in a lot of effort putting this all together, and you know, the performance so far on the cricket network has been fantastic. So it's really been great to be part of. Good to see Hamid on board as well. And a few other names as well. Amber, who's there, I can see, and Kaiser Saab as well. So yeah, great to be part of this.
Thank you very much, sir, for your comments. I think we have Professor Dr. Amber Ashraf. If we could have her comments, please, because I definitely see her in the panel.
Yeah, Assalamu alaikum. How are you?
I'm good, ma'am. We are all fine.
That's wonderful. You, mashallah, such a wonderful moderator. You put really John in this activity, and that is something really we appreciate. Both the teams played very well, mashallah, and that's really a wonderful activity because most of our consultants, we are participating and we are just thinking on the answers by ourselves, and that's a very good learning experience as well. And keep it up, that's what I can say. And Aga Khan team, really salute to you, and our P.I.C team, yes, they tried their level best. And I think so this is really motivational for the rest of the PGs, so that it's not only important to prepare yourself just for the sake of exam. These fellowship trainings are day by day grooming and add on in knowledge, skill, and very important thing is the attitude component. Please inculcate that thing at all levels so that you'll become a superstar of Pakistan. Thank you very much, Shri. And we really appreciate the Wilson as well as our main mentor and the idea behind it. And it's lovely to see Dr. Sohail Khan. He's really doing so well and helping the PGs, all of us at different platforms. Thank you. Thanks a lot, Ji.
Thank you very much, ma'am, for summing it well, summing it up nicely, like always, and for your very kind words. I think I do see Dr. Hamid Sharif there. Can we have him? Is he there? Dr. Hamid Sharif.
Yes, I'm there.
Oh, great.
Yes, I'm there.
Please.
So it was a nice match, and I'm very glad to know that both of the teams qualified in the end. And it was a very nice activity. Again, I mean, a lot of credit goes to the Wilson Pharmaceuticals for arranging this. I mean, this exercise is very important. I guess it was on our time as well, and we would have very much benefited from it. And mashallah, as you know, a lot of thought processing, a lot of brainstorming goes into these activities, and you have to study each and every detail. And I mean, this thing helps you in the actual exams in real life as well, as you must be knowing this. A lot of congratulations to Aga Khan. I mean, the way they answered the questions, I mean, it was probably unparalleled. I've never not seen any team answering all the questions. So a lot of kudos to them. Congratulations to the Peshawar team. But having said that, the P.I.C is still qualified based on a superior run rate. So a nice activity and very nicely moderated, I must say. Mashallah, you spoke very well. And I mean, we in RSC all know about your capabilities and your efforts. And very nice to see Dr. Sohail Khan, one of my teachers when I was in UK. And I still admire him a lot and still consult him in difficult cases, and he's always of great help around. So again, thankful to Hamza and his pharmaceutical team for arranging such a tremendous activity, and I hope this activity goes a long way in future as well. I mean, and I hope we do have an RIC team as well. I was very, at times, feeling a bit low down because RIC team was not in this meeting, and I just once said to Hamza that why RIC is not. He said, okay, next time, please. So hopefully it is in the pipeline next time. RIC, mashallah, is doing quite well, and it is throwing some nice waves in the field of interventional cardiology. To sum up, amazing contest. Very glad to see two evenly matched teams going head to head, and nice to see both of them qualifying. And I hope them good luck in their future matches as well. So thank you.
Thank you very much, Dr. Hamid. I think you're always spot on with your words and with everything that you do. So great comments again. Yes, we would love to see RIC. That's again what I mentioned to the whole Wilson's team as well, along with Hamza there. So hopefully our team from RIC is also going to be there. But I think we do have Dr. Saira Bukhari. She is the mentor of 𝐂𝐚𝐜 University Hospital Stars. Ma'am, your words, please. I think your team has done so well.
Thank you very much. First of all, I'm going to join everybody else to congratulate you on an excellent moderation. I think you kept everybody's spirits up, and that was very nicely done. I'll keep it short. I'm actually proud of both teams. I know I'm the mentor for AKU, but I'm proud of both teams. And I just want to reiterate one thing, that no aspect of clinical cardiology or cardiology in general is less important than the other. And I think the questions that you put out today were very well framed. And they also show that there is no aspect that's not important enough for us to cover. So I think they were practical questions, and I think they were well answered by both teams. And congratulations to both teams on qualifying.
Thank you very much, ma'am. It was a pleasure having you along with your team. I think very nicely put. This is what it's all about. I think winning or losing is part of the game, and we all know that. But it's the process that you go through. And in these processes, I think with this, we will have our trainees, our doctors coming up so well prepared, and they'll have a long way to go. And I think they'll nail down any exams. They'll kill the exams, I think, and in their practical lives, in their work, they'll be much better prepared. So I think all the credit goes to Pakistan Cardiac Society and Wilson's Pharmaceutical for coming up with this kind of a model. So with this, I think I would like to congratulate the whole team, and we are also moving to the next stage. And with this, I think that's it from the center, and I will be signing out, and thank you all for your participation. Great work. Well done.
Thanks a lot. Thank you. Congratulations to Dr. Saira.
So this is the points table.
Okay, so that's wonderful. I think now we're going to, before we leave, we must take a look at the points table. And this is the situation. So we have the #1 slot being taken by 𝐂𝐚𝐜 University Hospital Stars. Wow, I think you deserve it with the kind of performance we saw. While we were going through the match, we were calculating behind scenes all these run rates and everything. And we have P.I.C Warriors. I think they're also there. And they have with their net run rate. So well done. I think both the top two teams have qualified, and I think commiserations for HMC Stallions, but I think they'll be coming out stronger. Everyone has learned from this, and anything that anyone would like to add, please. So I think with this, it's goodbye.
How many
Allah Hafiz
matches
from my
are
side.
left, Dr. Hamza? How many matches left?
Matches.
Group B is complete.
Group B is complete, and we have the top two teams are going ahead. And in the next few matches, I think rest of the groups, that group will also be there. So inshallah, we'll have the next few matches for the upcoming stage, inshallah. Right. So I think with this, we now will make a move. And I thank you all once again. I'm signing out, your host, your moderator for the evening. And best of luck to everyone for the future games. Allah Hafiz.